Yeah. Okay, there we go. Yeah, so this image of the crab, which has really triggered somebody. And this person contacted me and said how she was feeling. So I'm going to get back to that in a moment. So with this slide, what I'm saying is that your knowledge and skills and compassion can make a huge difference in the life of a person experiencing cancer. And knowledge, as we know, is so important because not only is BodyTalk a language, but if we can increase our understanding about certain things, not just about cancer, but anything, when we can increase our knowledge, we stand in the front of the row when we work with clients. Now, perception. Now, I'm sure you've all done, or if you haven't, doesn't matter, but you've done consciousness. And if we think of perception, so I get this message via messenger telling me that this image and this person is a Cancerian astrological sign. And how can I use the crab with this talk that I'm going to give? So I explained to her the history of why the crab is important. And it was really triggering her big time. Now, of course, that is something and I said that's something she has to work with because this has got nothing to do with the astrological sign. And the astrological crab sign, the Cancerian sign, does not look like this in any case. It's a completely different image. So this is why I'm just sharing it with you, because perception is crucial within this context of cancer. So let's look at I want you to, for a moment, just somebody has told you, a doctor has told you personally, you have got cancer. I want you to write down 3 words, not more than 3, or if you haven't got paper now, just in your mind, not more than 3 words. What comes up in your mind if you have been diagnosed with cancer this morning or today? Just not more than 3 words. And it doesn't take long to write 3 words, eh? It's not something, it's just like that, what pops in your mind, that word, cancer. What does it evoke within you? And I'm just going to stop the share for the moment. Who would like to share? Who would like to share what are those words, or one word or more than one word that came up in your mind?
The first word that came up as you were asking the question was cost.
Cost. Yeah? Cost.
And my other 2 were time and pain.
Pain and?
Time.
Time. Thank you, Sansan. Anybody else want to share? There's no right or wrong. It's something that came up in your mind. What is it?
I said or thought fear of death.
Yeah? Fear of death. Anybody else?
I had
Yeah, Lorika?
fear.
Yeah?
My first thought was, oh bugger, I'm going to die, and I have so much to live for still and want to do still. So
Yeah. Christina, hello, Christina.
Hi, sorry I'm late. I had fear, uncertainty, and why. There's sort of lots of words underlying that, but yeah.
Now that is, thank you for sharing, and that is very general, because is there anybody of you that said, oh, fantastic, I can work on myself. This is about self-love. Anybody that said that? I'm sure not. If there is, I'm going to, I'm honestly going to kneel down in front of you, because these perceptions is coming from somewhere. It's coming from somewhere. So let's have a look at it. It's coming from somewhere. Now, where does it come from? It comes from your, oopsie. What's going on? Experience, self or work. Now, if, of course, for some of us now, we, especially if we have got some background in healthcare, our work we worked with patients with that diagnosis that experience cancer. Or it may be that the person ourselves, if we had cancer ourselves, our ancestry. That means, what is it in my ancestors? My family. Now, for instance, for me, in my family, there's a lot of different cancers. So it appears that in my family there is a potential for the cells to in an easier way, if the triggers are there, that there could be a change to cancer cells. Then, of course, the media. And then, of course, the Western and the natural opposition. So in healthcare, now healthcare, we know that the Western model, there's a lot of myths about cancer care, or a lot of myths about cancer treatment, because of these perceptions. And you hear that they're just going to kill my mom or my father or my sister or whatever, or they just did this, and it's a judgment that's coming because of ignorance. And so if we look at the Western model, it's not, I call it a Mickey Mouse. It's not the Mickey Mouse model, okay? And it's coming from very, very far back, very far. And I think we must just touch on the history of cancer that's influencing our beliefs, because those words that you've written down is because of a belief. It's your perception. There's going to be pain. Oh, I still want to work. I'm dying. And there's this fear of death. And so it's that bucket list thing. I still want to do this. I still want to do this. And there's pain, time, cost. And we know that cost certainly, it is a big factor in cancer care. Now, let's have a look where this comes from. Where do these beliefs come from? Now, Hippocrates was from 460 to 317 BC. That's not yesterday. It's a long time ago. And he was the father of medicine, and he was seen as the father of oncology. So that is at that stage. So you can now think there's the three big treatments for cancer: surgery, chemotherapy, and radiotherapy. But surgery is the oldest one. And from before Christ, they already worked with people with malignancies. And then Edwin Smith, the papyrus textbook, and they called it trauma surgery. That was in Egypt, 3000 BC. That is the oldest description that was found in a textbook about cancer. So if we look at Galen, it was 130 to 200 AD, the word onkos means swelling. So that is where they started to, in a way, change the word from cancer to oncology or onkos, and onkos in Greek means swelling. Now, and of course, any tumor, it is a swelling because it starts very in a cell and then it gets bigger. And then Celsus in 28 to 50 BC used the word cancer, and that's the Latin word for crab. And that's really where it comes from, and it has got nothing to do with the astrological sign. So now in the Egyptian era, what they found was what they described was 8 cases of breast tumors. And we still know today that breast cancer is one of the key cancers that women, not only women, but mostly women, are presenting with. And what the treatment was, what they called it a fire drill. They literally cauterized with the cancer, that tumor. That was the only treatment that they had. And then what they've written in those documents, what was written about the disease, there's no treatment. There's no treatment. And this still sticks into the minds of many of us today. And that is why, for some of you say, death, I'm going to die, I'm going to have pain, because there's no treatment. The global belief system, since that time, is still around us. Let's say it's still hanging over us as a cloud. And that is still there. So that is why we have these beliefs. And yes, if I think my own sister died of cancer, my father died of cancer, different kind of cancer. My grandmother died of cancer. My mother had cancer, but she didn't die of it. So this is where these kind of things, and what is happening in my family, or I know somebody, I know a friend, I know somebody that I cared for, I know somebody that I worked with and they struggled or they died. So it is very, very strong. And it's only when one works with those patients, which I did for a long time, and I was teaching oncology nurses for a long time, that one experiences that, yes, it's not a walk in the park. The treatment is not a walk in the park. But for thousands and thousands and thousands and millions of people have been cured from their cancers. And when they die of something completely different. So, and that part is never emphasized, because this other part, that with the struggle, it is just so big that people don't focus on that. Now, the beliefs, now the earliest beliefs. So, and this is really where the word or the cancer thing or the picture, let's say my image of the cancer, of the crab comes in. So when they cut a solid tumor, that means something is started and it's now big and it's there. It appears like it has got turgid veins shooting from the center, and it resembles the figure of a crab, because what they believed then, where it got, once it's got in there, it is scarcely possible to drive it away. So it's a bit like we all look at nature. I mean, I'm a nature person. Nature comes in my BodyTalk sessions all the time. So it is our connection to nature. I mean, if you look at the skies, the astrologers, something looked like as something in the sky as the stars are put together. They refer to it in a nature way, what it looks like. Now, the same here, those people, it looked like it. So it is not clear if it was stated by Hippocrates or Paulus of Aegina. but it comes a very, very long way. Now, what are these things? So if with that belief that once it's there, you can't get rid of it. And this is why these beliefs come. Hopelessness. Once it's there, it won't go. It's hopeless, it's helpless. Pain, suffering, no treatment. So there's no treatment that can cure this. Death, like some of you have experienced, and the fear. And there's nothing wrong with it. It means it's just coming from so long. Now, our personal beliefs, or the personal beliefs, is that it can create inner conflict. There's guilt, there's grief, suffering, persona identification, repress own negative feelings, self-rejection, low self-esteem, loss of purpose, despair. Now, some of these kind of things, when you work with a person that is at the moment experiencing a cancer diagnosis, these are the things that could come up. Those can come up within the client. Now, for instance, with breast cancer patients, they often, if you can just mute yourself, that we don't get any, they can often be a relationship with guilt and the mother, or a relationship issue with the mother, because now this is where your work with consciousness really comes in. Because then if you think of the breast, we learn about the breast. What is it about? Nurturing. It's about, so if there wasn't nurturing between your client and their mother, that could show up now. So that can be part of what you are going to deal with, to eliminate, to do through a matrix, to repair that relationship, or whatever the case may be. So this is where we can get some information. This is how we work with it. And of course, as we say, you've got the consciousness states of the specific organ, endocrine, or body part, where the cancer is expressed. But we also know that it can be anything. So here for me is, as I say, if you can get the golden nugget with consciousness, with any person who has got cancer, you can fly with that person. But it is not that easy. And I'm going to just stop sharing, because I want to share something with you. Because what is to happen here is, if we really just get one consciousness and that person gets such an aha moment, because any disease, but if we look at cancer, so it's any disease, we moved into a ill or disease matrix. And to get out of that, we have to move into a health matrix. Now, I want to share this with you, because sometimes with these serious illnesses, especially with regard to cancer, we can get, it's rare, but we can get a spontaneous healing. Now, what is that? What is a spontaneous healing? And I'm going to give you an example. We had a patient, this is now in donkeys years ago when I was still in cancer care. I was already teaching, but this was now in 1981, around there. And this patient came, the first time she came to a radiotherapist, a doctor, specialist, with lung cancer. And when they took the x-rays and everything, and he showed us, it would look like just two white, dense lungs, white, on an x-ray, okay? And that doesn't look good. So he decided, well, and they pushed her in on a trolley, on a stretcher. He decided if he treats her in any way, not even palliative, he will kill her because of the disease that's there. And he then just prescribed, he spoke to her and he just prescribed pain medication and sent her home.
Okay.
After a month, and he thought he will never see this person again because, I mean, the situation that he was looking at was absolutely untreatable, and he supported her with pain medication. So then, after a month, there was and he looked at his diary and he said, "But well, what is this person doing here? This patient doing here?" They pushed her in again on the trolley. They sent for X-rays and everything, and the lungs looked better. Still, he decided he cannot treat her because he will just, with radiotherapy, he will just actually kill her in that moment. More, send her back home again. 2 months later, they pushed her in again. He looked at the X-rays and he thought, no, but she was in a wheelchair. He decided, but they've sent the wrong X-rays. He contacted her. No, it's not. That is the person's lung X-rays. It was clear. She had no treatment. So that was like 2 months after he first saw her, and the lungs were clear. So what happened there? She went through a spontaneous healing. So in our field, and if you look at the 5 levels of body that we all learned about, physical, vital, mental, supermental, bliss. What happened actually there was she went from a illness matrix, she went into bliss, because when we're in bliss, we don't need anything. She went through the bliss body and healed and went completely into a health matrix. She had nothing else whatsoever. Nothing. And so this is where, but when we look at that, for me, it's the soul journey. Because it's only the soul, and I'm discussing this because to help you, that if you get somebody and you give the most incredible BodyTalk sessions, and this person still passes on, you cannot feel guilty or think, what should I have done in any other way? You have to understand that it is the soul that decides, am I going? I had enough experience in this lifetime, or am I going to stay? Now, I'm going to share something personally. When my sister was diagnosed with inoperable breast cancer in 1994, and she had chemotherapy, radiotherapy, everything, and she was clear for 8 years. And according to information and research, her life expectancy wasn't longer than 5 years because of how far it had already developed. And then, so in 2003, when I started BodyTalk, I was convinced that BodyTalk can heal her. And I did sessions on her every week. She passed away in 2005. Now, why am I saying this to you, telling you this? Because, as I say, to work on your own people, I will always do, because it's not, for me, not an option to say you can't. But I always, at the end, she one day said to me, do you know what BodyTalk has done for me? I said, what? I'm glad that I sat on a stool. Because what did I want? I wanted to heal her, to heal physically from the cancer. And she said to me, now she's got one daughter, And at that stage, her daughter and her husband went through a very difficult financial period. And my sister was like this. If you ask if she asks you, son, how are you? And you say, oh no, I'm feeling terrible, man. Within 15 minutes, she feels exactly the same as you because she just absorbs all of that. And she said to me, well, what BodyTalk has done for me, BodyTalk has helped me because I look at my children and I know I can't help them financially. It's something that they have to go through themselves. Well, I mean, I nearly fell off that stool. So what BodyTalk has done for her was pain control. She did experience less side effects of the therapy. But the big thing was it prepared her in a beautiful way to transition over when she passed. And so I had to really, it was a big, big lesson for me. And that is when I had to understand as well that it wasn't her choice. It was the time that the soul decided it has enough wisdom for this lifetime. And this was a door, a gateway to exit. Okay. So it was, if we look at our Percival Pott, it was in 1775 where he linked the environment to cancer. And this is, now we also know, now Bruce Lipton, it is the environment, stupid, that's in his book, when he looked at cells and he saw that the cell can only stay alive if the environment is correct. So that means if there's enough nutrients. So when we look at cancers, cancer plays a very big role, or environment plays a very big role within cancer, the development and in the treatment. Because the cell and the cell membrane is very important, because if the cell membrane of a cell is damaged, the cell can't survive. So then the start of epidemiology, so epidemiology is where does it happen? And so here it was the scrotum cancer in the chimney sweep. So the chimney sweeps, they got cancer of the scrotum, and so that's the environmental thing. And so the polycyclic hydrocarbons are carcinogenic. Carcinogenic just means it's factors that can be harmful to the body, and or that's over a long time, over a long period. That means it's a constant trigger, and that can make the DNA change to cancer cells. And then in the 19th century was really, that's the other way, a little way back, is the birth of scientific oncology. And that is where the modern microscope, he started, Rudolf Virchow, he started, and he was be seen as the founder of pathology, of cell pathology, where they could look it through the microscope and then really see what was going on there with the cells. Okay, so cells is the essence of cancer development and treatment. It's all about the cell, and the more you understand about the cell, so some of you that's here, San and Miriam has just passed her, Miriam has just passed her anatomy, 2-year anatomy. So once you understand the cell, you can understand that that is the essence of cancer development and treatment, really of probably any development of any disease, but specifically in the treatment of cancer, it's all about the cell. When is the cell going to divide again and to develop more? Now, cell functions. So here we have got in healthy cells. So here we've got the cell cycle, and this is what's important, the cell cycle. Now, in healthy cells, we've got proliferation. What does that mean? It just means the formation of new cells through the process of mitosis. Mitosis, the cells divide into two, and then if they don't stop, there's another two, and then there's another. And destroyed cells are replaced by a remainder cell of the same type. So there's a mother cell. So if one skin cell is damaged and needs to be replaced, I just need one. I don't need two, just one. So this is like demand and supply situation. So let's say for our discussion, we only got 100 cells in the body. I don't want 101. I only want 100, which means that within the body, we have got chemicals, we have got a variation of processes that actually keep my 100 cells. And only when I lose one cell will one of the mother cells in the same area divide, and I will get that new one cell. So that then it will stop. Now, in this picture, here is, and you don't have to remember this now, it's just for you to understand when we talk about the therapy. So here, the cell cycle has got a G1 phase, a S phase. So in the G1 is the cell with chromosomes in a nucleus. The S phase is the DNA synthesis, where the chromosome is duplicated. The G2 phase is duplicated chromosomes. And then the M phase, the mitosis. So this is where the chromosomes separate and then the cell division, and we get two cells. So that happens in our body all the time. Now, how are these numbers constricted? By the 12th week of embryonic development. So when you're 12 weeks old after conception, there's already contact inhibition. So contact inhibition means I'm just keeping the skin. I've got a skin cell, it's damaged, it's going to be replaced. So soon as the new skin cell is there, it now recognizes itself. It recognizes itself that it's next to another skin cell. So stop. You don't have to replicate now again. And the non-self, if it is also next to another type of cell, let's say a blood cell or a muscle cell or whatever, okay, that's not the same as me. I've got to stop. As that recognition. So we can look at it from a consciousness base. Okay, I can see you are a BodyTalk practitioner, you're the same as me, but as a non-self, we look different. Okay? It's the same principles of consciousness. But there's complex mechanisms or cell inhibitors, chemicals in our body that is controlling my 100 cells that I have in the body. Then, of course, we've got differentiation process, and this is also very important because now if we are in conception and now the sperm and the ovum starts they joined, and now they start developing. We get the morula, and it's just a group of cells. And now specialization starts. Some of them are going to emerge as the nervous tissue, the spinal cord, and the brain. Others are going to go into the heart. Others are going to specialize in the stomach cells and the muscles and whatever the case may be. And this whole differentiation process starts at day 8. And day 15, there's these 3 layers, ectoderm, mesoderm, and endoderm, that are formed. And the 6th to 12th week, organogenesis, that's when the organs are formed in the fetus. So it is a process that's absolutely part of our bodies. Now, the common characteristics of cells is, of course, it needs nourishment to maintain life. Use identical nutrients. It uses oxygen. We can't be without oxygen. And then those nutrients are then changed within the body into energy, like, for instance, the liver, as you know that. Now, if we look at the cell cycle, so there's 5 phases of development. So it is G1, G2, S, G2, and micro. And if they go into the differentiation, is the process that it goes into the go phase, where these developments, how they go into specialized cells develop. And that is the resting phase. And that is just normal activity takes place here in the go phase, G0 phase. Just normal activity. The G1 is the RNA and protein synthesis. And that can take several hours to days. Now, I've put the hours here because you're going to see when we talk about chemotherapy, how they give chemotherapy, how they prescribe it, and when the patient is getting it. It's all to do with this kind of stuff. Because the chemotherapy, some of them will stop or interfere in the M phase or in the G phase or the S phase. So if they know, this is several hours to days, that if they, so it's a bit like, I don't want to say hit and miss, but in a way it is like that. Because in what stage are the cancer cells? Are they in which stage are they here? And they are trying to hit the cancer cell if it's in one of those phases, according to which chemotherapy is used. The S is then the DNA synthesis is between 10 and 20 hours. The G2 is 2 to 10 hours. And then the mitotic phase is fairly quick. It's between 30 and 60 minutes. And that is when that is happening, the mitotic phase, the mitosis, the DNA is exposed. And it's from the DNA that must divide. Hey? So if it's exposed and we can get treatment while the DNA is exposed, the cancer cell, to really stop that or interfere with that, that is where they will get a lot of success. Now, if we look at the cancer cell and we look microscopic, so we're looking at the cell under the microscope, they vary in size and shape because they lose. So let's say we talk about a breast cancer cell, and it's, let's say, so because what happens, if they take a biopsy, so it's sent to the laboratory, they can see, where is this coming from? Where did it start? So let's say it is in the breast. So, but now they don't look like breast cell anymore. They can be very in size and shape. Chromatin are more prominent, and the unusual number. So they just are unusual. There's translocations, there's loss of chromosome sections, there's extra chromosomes, or there's weak sections on chromosomes. Cancer cells can mimic anything else in the body, any other. They often mimic thyroid issues. It's not a thyroid thing, but they mimic what the thyroid does. Now, the cancer cell cycle, point of decision to replicate or differentiate. So what happens is they divide, and then instead of getting mature and specialize into into the adult cell, they now go into replicate because they have escaped. They have escaped the controls within the body, the chemical controls, and they can't stop because they don't look the same as the other cell anymore. So there's no self-recognition, there's no recognition there. So what is lost? It's the behavior. It lost the proliferation control. Control mechanisms fail, and carcinogenesis start. So organogenesis means it's how organs are formed. Carcinogenesis is the process of cancer development. That is what happens. So this is where normal cells transform into cancer cells. And 80% of human cancers result of exposure of environmental carcinogens. Now, I want to just come back. If we look at BodyTalk and we say that consciousness is all there is, and that we are responsible for our own health, and that we are pulling in things, our health, our wealth, whatever. It's a consciousness thing. However, that is true, but environment plays a massive role in the development of cancer because of the carcinogens. So if we just look at pollution in the world or in where we live, doesn't matter, in our country or around the world, that exposure to pollution at a constant time can allow the cells to, or will affect the cells, and it can change, because it is an irritating, something is there and it's constantly there. Now, any cell that is, once you can identify a tumor, preventative stuff, early. Ilana, can you just mute yourself, please? Okay, I'll just mute it. So it is that constant exposure to chemicals that will play a very big role in cells, why cells are actually developing into cancer. For instance, if we look at digital toxicity at the moment, now I always cringe when I see, and I hope none of you are doing it, your cell phones or your mobile phones, and you have these ear plugs in, and you speak through that, you listen to your phone all the time, doesn't matter what it is. A lot of people that's on the road and trucks and all of that, they have these things constantly in their ears. Since this kind of thing has happened, since we went into cell phones, digital toxicity, there's just so much radiation from your computer, from your phone, from wherever. There's been a huge increase in brain tumors. And that's a fact. That's research. It is an absolute fact. So don't put the thing in your ear, and not for, if you have to put your phone on the speaker and speak through that, because we have to look after ourselves. And then so we have like what they say, promoting agent or several carcinogens. So we're so exposed to everything, and of course what we eat, all the toxins we're getting in, all the things that have been changing in the world can affect us because it's our environment. So now with the cancer cell behavior still, a tumor must go through 30 doublings before it's palpable. That means it has got 30 times that it has went through mitosis before you can even feel it. And the minimal clinical detection, that means to detect a tumor through a X-ray or through a mammogram or through a scan, it has 10 billion cells, which weighs 1 gram. 1 gram. And this is just for you to also understand how small are our cells. They're 1,000 of centimeters big. So you can see now, if 1 gram of tumor, that's when you can hardly, it will be like the size of a small petit pea, because that means one can detect it and perhaps feel it. Let's say if it's a breast tumor, but if it is detected by a gadget, by a machine, there's 10 billion cells there. So tumor at the time of detection is usually 100 billion, and it will weigh 10 grams, which is actually nothing if we look at weight. Now, the death of a host. So if somebody has got the disease, so that means the person will pass on when the tumor mass, that means within the body, exceeds 1 trillion cells or weigh 1 kilogram. So if there's a kilogram of weight of cancer in the body, and it doesn't mean in one area, that means it has spread throughout. So in total, if there's a kilogram of mass in the body, the person will pass. And this is why. So tumor growth from 1 gram to 1 kilogram only requires 10 more doublings. So if you think 1 gram to a kilogram, it only has to multiply 10 times, double 10 times. And it's like, if you look at your ancestors, we say we've got 2 ancestors and they've got each 2, it's 4, it's 16, it's 32. It's in that way how we look at doubling time. It is only more than, only 10 more doublings. And this is, if you understand this, you can imagine, or let's say we can also understand why these treatments are can be severe, because what the doctors are trying to do is to stop this duplication of the tumor cells within the body. And this is why, I mean, some of you said, I'm going to die. So then, would you go and have treatment to stop that? Because if we don't, then we will certainly get to that death part. Hey? So tumor growth factor, we call it GF. What is it? It means it's the ratio of total number of cancer cells to the total number of proliferating cells. So we've got cells, the number of that, and to the number of cells that is proliferating, so to change that or at the periphery of the tumor. And the inside cells are hypoxic. So if we look at the tumor and we say, okay, so the edge of the tumor, that is, those cells are dividing, they're proliferating. But the center of the tumor, there's no oxygen, it's hypoxic, and those cells are very resistant to the therapy, any therapy. So now, if we look at the cancer cell, there's loss of differentiation. So that means the cell that is started in the breast, and a breast cell, now it's lost. It can either be well differentiated, so when they look under the microscope, they can say, okay, it's coming from a breast cell, or it's coming from a liver cell, or that means where it started. Or it can be undifferentiated, it has lost already those characteristics. Or anaplastic is the most difficult one to treat because they don't know at all where it started. Not at all. If it's well differentiated, the treatment protocols they know that for breast cancer, these treatments are the best to give it a better chance. If it's undifferentiated, it's already more difficult. But if it's anaplastic, it means they've got no idea where this is coming from. It doesn't matter where it is. Where it started, that is the most difficult to treat. So we've also got altered biochemical properties, inappropriate secretion of hormones. Often, like for instance, lung cancer can secrete hormones and give you the picture of Cushing's syndrome. And then we've got tumor-associated antigens. So this is what they will send blood away, and they will ask for very specific antigen testing to see, is this tumor active in the body at the moment? And this is what they will do throughout the treatment of the client. And then of chromosomal instability, a mutant. So the process of being altered or changed, cancer cells develop this unique characteristics that make them highly resistant to therapy. And this is why the therapy is, they always give more than one kind of therapy as well. And then the capacity to metastasize, spread of cancer from a primary site to a distant. So for instance, let's just take the breast cancer again. The breast cancer starts in the breast, but once it's spread, and let's say it's going to bone, when they take, that means it's the breast cancer cell that is now in the bone. It's not bone cancer, it's breast tissue cancer that's there. Or if it goes to the brain, it means if they would take it out there, it will still be breast cancer that's now in the brain. That is how it's spread. And then, of course, there's the production of enzymes on the cell membrane. Now, the roots, how does cancer spread? And this is important. This is important for us. Direct, very direct. So it has the ability to penetrate and destroy tissues that's next to it. And there's cell motility, so it can really, it moves. Loss of cellular adhesiveness. And then tumor angiogenesis factor. Metastatic spread, that's direct, next to it. How do I get to another area? So let's just take the breast again. How do I get from there to the brain or from there to the spine? Number one, lymphatic. And it was in 1685 to 1770 that Henry Francois Dran describes lymphatic spread of breast cancer. Now, what happens here? Now, you know, if you look at your BodyTalk protocol, you know that when we're doing when we do in section 4, circulation nerve supply, and you know, when we explain it, it's like, why is lymph not to, it is only within and from an area? Because we've got these tiny, tiny little vessels, and then the lymph will go through that, and then it gets back into the bloodstream. Now, this is exactly why this is so important, because if we look at the breast again, so the breast, it goes easily through the adjacent cells, and there's lymph, and there's a little lymph vessels, and now it enters, because the lymph vessels one cell layer, it goes through there, and it goes into the lymph, and it goes to the next group of lymph nodes, and it gets back into the blood system. And this is why when people, and specifically breast cancer, they will, where's the biggest group of lymph nodes? Here in the axilla. So they will always take, the surgeons will always take some of these glands and have it examined, so they see, are there any cancer that is already spread to the lymph? Because that means it's away from the breast. So it's like, okay, now it's there. That means it's put them already into another category. It's not local anymore. It has spread to the group in your arm and the axilla. So this is direct invasion of lymphatic vessels, and then it goes into the lymph nodes, and from there it enters the blood circulation. Now it's in the blood circulation, and now it depends on where is it going to get stuck in a way. It can be the brain, it can be the liver, it can be the lungs. Now, for cancer people, if it's local, it's the best. If it hasn't metastasized yet, the doctors get worried, and it gets difficult if it has spread to the organs like the lungs or the liver specifically, or the kidneys, but specifically those two, because it has such an important role. And then, of course, the brain as well. But I mean, if it's the lungs or the liver, that is not a good thing. And then, of course, obviously, when we have a spread of cancer, it already puts us in that stage where there's so many cancer cells now. And if it's not stopped, the next phase, I can get to that 1 kilogram if I don't get the treatment, okay? And then through the blood, the tumor must be 1 centimeter. That means 10 billion cells before metastasis is possible, before it will break down a piece and it will go down there. It's usually about 1 centimeter. The secretion of angiogenesis. Now, angiogenesis means blood vessels. Anything that we need blood for survival, because there's nutrients that comes via the blood to the cells. Now, the cancer cells are so clever. They're so clever. They create their own blood vessels. So vascularization at the primary site, because they just want nutrients. That's what they want. They want nutrients, and they will take the nutrients of the host at the cost of the host. Now, this is a little bit how it will happen. So let's say this is the primary site of, let's say, breast tumor. So it creates its own vascular system that will, so circulatory transport to a secondary organ. So here it's got its blood vessels, and there it goes, and it gets into the heart. Detachment of the cancer cells from the primary and the blood capillaries. And then from there, 1 million cells enter the blood circulation per day. Now, I remember that all of us can have cancer cells at any moment. But when our immune system are healthy, and because it can recognize that this cell is not supposed to be there, like we will then call the killer cells, your lymph T killer cells, those are the army guys, the soldiers that clear out these cells for us on a daily basis. But when we go through all these other things and it doesn't do the job, then it will start. So when we look at this, less than 1% of these million cells become metastatic lesions, less than 1%. So there's still sort of like a very good position and options that it won't metastasize. It is like, when does that get out? And this is again for me where soul journeys come in, those kind of things. What is it that my client is attracting? So then we've got here a capillary. Let's say this is a capillary in the lung. And so here we've got adherence onto capillary in the secondary site. So there is now the lungs, and now here are some of the cancer cells. And now it's going there in the lung. And this is now, these cells go through, they move, they slip through the wall, and then they go into the lung, and that's where they will then start directly, and that they will develop. And this process we call extravasation. That means the potential that the cancer cell has to move through a lumen, through a vessel, wall of a vessel, wall of a lymphatic vessel, because it's like they move through those cells to get out. So they escape from the circulation. So this extravasation from the capillary wall is to invade the tissue that's next to it. So here we've just got like a little diagram. So we've got the primary where it started. Then there's vascularization, and then it gets into, those are the vascularization, those tiny ones. And so it gets into the veins, it gets into the heart, through the blood, can go to any organ. So let's just say here it's the lung, and so this is how it gets there and metastasized. So with angiogenesis of the metastatic implant, we get these small clusters of up to 10 million cells. And then
Nouvelle de Yeti?
to grow,
Yeti? Eh.
and to continue growth needs vascularization again, and that whole process will repeat by itself. So now the other thing is, of course, if you think of COVID-19, when that came about, the first one was awful, and then there's still COVID, but it's less impactful because the cells that went through mutation, the viruses went through mutations. And so here in the cancer cell, they can become dormant. It's like they go like become mutant and they become dormant for many years. They can be there for 20 years. The person can be healthy. Nothing has happened. And all of a sudden, they come with a metastasis. And then it's usually quite drastic. And then the person says from the remission does not mean no cancer. That's why cancer patients are never, ever, ever discharged. They will, in the beginning, follow them up every 3 months, then after treatment, then 6 months, then a year. And so they carry on. Even for 20 years, they will never get discharge them totally. So the cancer, when they are in remission, it means the cancer load in the body may be less than what is clinically detected. So less than 10 billion, less than a gram. And they are never discharged, as I say. So these, what is this? Okay, so now let's look at the grading of the tumors. The grading means if somebody has got diagnosed now, what kind of protocol, what suggestion is going to be given to the client, how they can be helped through Western treatment. So this is stage 1, stage 2, stage 3, and stage 4. So stage 1 means it's easy to, like, this is started in the breast, this started in the stomach wall, this started in the liver. Stage 2 is moderately, so there's sort of like there's some signs where that comes from. Then stage 3 is poorly differentiated, they don't really know where. And stage 4 is that anaplastic, completely, they don't know where this tumor started at all. Then we've got a universal classification, T&M system. T stands for tumor, and that is the size, the extent, and the depth of the primary tumor. The N means extend beyond the tumor. That means the regional lymph nodes. That's why I said if a breast, they will always take glands out in the axilla. And then M stands for the absence or presence of distant spread of the disease. So has it already spread? And that will put us then in a different category. And before the treatment starts, they must have histology. You can't just give anybody chemotherapy or radiotherapy. They have to have proof that this person has got cancer in the body. The grading and the stage is important because that depends. Now, if we look at cancer therapy goals, and this is where we come in, where we can see, okay, where do we fit in as BodyTalk practitioners? So when we look at from the Western model, if there's a possibility of cure, that means the tumor is small, it hasn't spread yet, and the chance of cure is very good. So there are other options here. It's like a prevention method. It's combination. They will use definitely combination therapies. Very aggressive. It's like they're going to go all out. So the dosages are higher than because the possibility for cure is there. Then in palliative care, so let's say the person there's a lot of spread, or they have had cancer therapy before, and now after many years there is now spread in the body, and they are now not they can't go for cure anymore. They will go for palliative care, which means it's minor interventions. They can give a little bit of radiotherapy, which can help a lot with pain, especially if there's bone metastases. And so it's all about symptom control. The same with chemo, it's very small doses. In BodyTalk, so where do we fit in here with the treatment of this? Regular sessions, because if you do regular sessions on the person, it is and I would say now this is where Sansan mentioned the cost, and that's a very real thing with cancer, because these things are very costly. And the thing is with BodyTalk, it's additional cost now, hey? Because now they may not be on, of course, BodyTalk is not covered with medical aids or health insurances, so they've got to pay for that. And it is when they experience the influence of BodyTalk and how it can improve their quality of life by going through the treatment, and also to get the message. When I always say, are we getting the message here? What does it mean to you? What is your lesson? Have you got the lesson yet? Why you're having this disease? Why you're experiencing this? So regular sessions, this is a lot where the consciousness stuff come in. That is beautiful. But then the other big thing is reduce the side effects. Because when you know what treatment, so I always suggest that ask them, the doctors, to write it down for them. What is the treatment? What is the treatment? Because you can Google the side effects. And even today, I will, with my client that we just finished her sessions, and she's in remission. So that means that tumor load is very small. So she had sessions every time before treatment, every time. Now, the reduced side effects are huge, because I know it, and so I would sometimes Google. So she gave me the number and the names, and I thought, okay, this must be. She gave me a name, and I thought, okay, this is Taxotere, because I know it. That's not an issue. I know it, but I wanted to make sure if it, because sometimes what they will do through the years, they will, depending on who produces the drug, and they will change the name. But there are telltales about how these things work, and I'll talk about it a bit later. So we reduce the side effects, and then emotional management, because that's huge. You can prepare the client spiritually, and it works very well with pain control, as you know. So now let's look at the cancer treatment. Are you all still good? Yeah? So cancer treatment, we've got surgery, we've got radiotherapy, and we've got chemotherapy. Those are the three big ones. We've also got immunotherapy that has been really coming a lot forward, and that is for, like, for instance, blood cancers. And I'm not going to touch on immunotherapy at the moment. I'm just going to, because it's still something sort of like within the chemotherapy genre. So, but let's look at these others. Now, in cancer surgery, it's the oldest one. It is still very much prominent in today's cancer management, although it is less intrusive. It can be less intrusive. So it's always still used for diagnostic, because they have to send some tissue away for the histology. They can't do anything else. No treatment before they're not absolutely sure that this is a cancer. So preventative, you can do preventative surgery for certain families. If there is polyposis of the colon or anything else, you can do a preventative. The patient hasn't got it yet, but they can have preventative surgery. Then curative, also curative used to be more bigger in a way. It's a bigger surgery because they will remove everything. And for instance, if you think, and they remove glands and all sorts of things. Today, because of the chemotherapy and the radiotherapy, it can be less mutilating, the surgery, than before. And then palliative, again, it's small. It is just releasing or relieving some pressure around an area, or they can cut through nerves to help with pain, all those kind of things. Now, where do we fit in? Performance sessions, of course. Performance sessions to prepare the person for the surgery. And I find that always works extremely well because they recover much easier and quicker. And so now with BodyTalk and cancer care, the very first thing when I speak to the clients is to listen to their language. Listen to their language. And then I will say to them, say that for me again. What is our issue here? And if they say, my cancer, that is where I stop them in their tracks. And I said, say that again and listen to what you've just said to me. My cancer. So do you want to get rid of it? Yes. So how are we going to get rid of it if it's yours? Because you've already personalized it. They've already taken it on. Now, and that is with any disease, not just cancer, with anything. My fibromyalgia, my whatever, my diabetes, my whatever. They've already personalized it. So if you look at your BodyTalk module 3, it is that general brain where it plays out your belief about what cancer is, your belief about what is illness and health, those kind of things, is that general concept. Now, in cancer surgery, especially here at the diagnostic phase, if somebody has to go and have a biopsy, the emotions are huge. It's that fear. Is it going to be positive? When I say positive, is it going to be, we talk about positive. Yes, cancer is not positive in emotion, but if it's positive, that means the cancer is there. If it's negative, it means there is no sign of the cancer. So this is where you can help them to prepare them for what they're going to hear. And then you can, now fragmentation, I put fragmentation, defrag here, orthogenic and morphogenetic, is I have actually once, it was a small breast tumor. And she had a familiar, was in Australia, she had a family history of breast cancers. And I did a fragmentation of that little tumor. And it disappeared actually when she went for the second, for the second mammogram, there was nothing. So this is where your advanced work can come in if it's an early, and even if it is not that early, but because what we are saying about the tumor, that on the edge of the tumor, the cells are, there's oxygen there, but in the center, there isn't. So the cells are hypoxic and it's very difficult to treat them. But you can use fragmentation. And of course, the other thing I use is neutrons, but we'll get there when we get there. Now let's look at, and of course today with the surgery, there's the keyhole surgery and all of those kind of things that is making it easier for, it's not so mutilating, especially in the early stages. It's easier for the diagnosis. Now, radiotherapy, very, very interesting. And that's why I can't leave this out, because I want you to understand it. Where is it coming from? And the correct word is radiation therapy. Okay, not radium. Radium is a specific part and we're going to look at it now. So in 1895, Röntgen discovered X-rays. And since that time, they could do X-rays. And in 1898, the first successful radiation treatment was done. Now, X-rays, that's why when you go for a lung X-ray or chest X-ray or any X-ray, the people are not in the room. They put you there, they've got a little badge here on their shirt or jacket or something. And because it is of radiation, it is emitting radiation. And so the people working there has to have that to identify just by working there with the machines, what is the exposure that they're getting. So the first radiation was 1898. And in 1903, radium effectively treated tumors. So now here comes the thing. And let's just go back one. Let's just go back one. With radiation, now Marie Curie, very, very well known. She was Polish. And she and her husband, but they later lived in France. And they there had, it was given, they were at the university and they worked, and she was working with radiation because she discovered radium. Now, like cobalt, it's a natural, we found it in nature, in the earth, and so is radium. And so that is, it constantly, it emits radiation waves. Now, when she identified radium, so she didn't know that this was dangerous at all. So she had these little radium tubes and in her pocket and in her desk drawer and all these kind of things. And she got a Nobel Prize for her work and her research. And in 1903, this is the interesting thing, 1903, she was given the Nobel Prize. And at the event that she and her husband were, she received the prize, but because she was a woman, listen to this, she wasn't allowed to speak. So if we look at, and why I'm bringing this up, because again, it's just, if we think of, I mean, we've got a gentleman with us here, so, but for women, that's why if you think of thyroid, throat, it was the other day, 1903. So this whole thing that we can't, that the woman's voice hasn't got value, it's also an age-old thing, but it's very active, very, very active. A couple of years ago, 1903. Any case, so she died in 1939, I think. She died of anemia, a certain type of anemia that would have go over if she wasn't treated, or if it went on, it would have ended up as a leukemia. Now that was because of radiation exposure. And this is why when your client is having radiation therapy, is to understand they're going to be alone in the room when the machine is put on. Nobody else is going to be with them. They will be spoken to from outside. And because of that, so then in 1920 to 1940, studies on the effect of radiation on tissues was done, early and late effects. Now, the early effects is what some people will say, oh, the doctor burned my mother or my father. No, the doctor didn't burn anybody. It is the radiation effect, it is the skin effects that is there. And you get like red, and that is why you can't, and this is where our language, how we can help people understand, because they don't wash with soap at all, and they just literally, if they have a shower, stand under the shower, and then they just pat themselves dry, because you can increase that effect. So it is very important for us to understand that. So that is, we also get late effects. Now, late effects is, for instance, fibrosis. Now, you know, fibrosis is a scar. So if we look at radiation effects, or when we prepare people for radiotherapy, it must be in our back of our mind that we want to prevent scars from the radiation. And there's a total dose for life. Now, total dose for life means that if I have a certain amount of radiation, I get to a certain amount for my body size, and that's it. I can't have any more. So that means my total dose. In 1952, the other day, was the first treatment with cobalt, which means cobalt is the source. It's about 1 centimeter by 1 centimeter that's hidden here in the head of a machine. And when it's open, that means that radiation will come out, and then it will go onto the person, into the field, because they will set it up how it must be. Now, that is a natural, I call it a natural source that comes from the earth. And then in 1955, linear accelerators for deep penetrating tumors were developed. Now, it's like a big X-ray machine, okay? Because it can develop these high frequencies. Now, it's a local therapy. Radiation is always local. I can't have over the whole body, okay? So local therapy, it means it comes from external, it's out there. I can have radioactive implants, which they will use like radium, and it's like little gold pellets, and they can insert that into a certain area. That means it's just around that area. And then radioactive isotopes is what we swallow, especially for thyroid cancers. Now we've got the kilovoltage machines. So what do? They produce an X-ray, but it's a low-level energy. And it's superficial for skin, like for skin cancers, that they will use that. Then we've got megavoltage machines. So that is where the source, like the cobalt-60, is a natural source. That thing is about 1 centimeter cubic, 1 centimeter. It's only replaced of between 5 and 10 years, depending on how often they use it. It produces gamma rays between 1 to 4 megavolt. But they go deeper. So it means tumors that's deeper than the skin, they can treat with these megavoltage machines. Now we get super voltage machines. That's the linear accelerators. And today, I want to say that the linear accelerator has sort of like replaced some of the others. So they produce X-rays and electron beams. So if you know about the atom, and around the atom there's electrons, they produce a beam of electrons, and that's to between 4 and 35 megavolts. And that is to treat deep-seated tumors because of the power of the electron beam. That means it can penetrate through the skin into the body so for where the tumor is. And then we get the cyclotron. Now the cyclotron, there's a couple of centers in the world, and we have got one here in the Cape at Fora. So the cyclotron is a particle accelerating machine where positively charged particles can acquire energies to up to several million volts. Now, those machines are a lot used for research, but for treatment, they can use it, like in Cape Town, we have got it. So this is where they split the atom and proton beam of 200 megavolts for patient treatment. So it means that it means that it reach a velocity which enable them to travel around the Earth in 1/5 of a second. 1/5 of a second. So you can imagine, well, I can't actually even imagine it because it's so fast, it's so powerful. And so since 1932, it's known when the element beryllium is bombarded with alpha particles to give off streams of neutrons. Now, neutrons, I use neutrons because I know how it works. And what I'm saying to you is that it's just a consciousness, okay? It's just a consciousness. Now, neutrons is very neutral if we look at what in the cell, we've got the protons, we've got the electrons outside, then inside the protons, it's a positive charge. The neutrons is neutral. So how do I use neutrons in cancer care? Or not just in cancer care, I use it quite often in many different ways. Because of it either depends what I'm doing. I'm using at the neutral effect. I want a neutral effect, so I can use neutrons to neutralize something. I have used neutrons to, it was here in Cape Town, and she's passed now, but she was a judge in the Cape courts, a judge. And I used neutrons. She had gallbladder stones. She found me on a Friday evening, and I used neutrons to break it up. Because she said to me, if she's going to have to go for surgery, I broke it up. We broke it up with neutrons. It's because I understand that the neutrons, because it's 3 times more destructive than protons, and it can go very deep. And for instance, in cancer care, it's used for resistant tumors. So those hypoxic cells, that's right in the middle there of a tumor. And if it's deep in the body, the neutrons also, they don't have the scatter, we call it the scatter. So if it comes out of the machine, it comes out and then it's like a triangular shape. So the tumor is in the center, but it affects more than just the center of the tumor. And so that's what we call scatter, but it's more direct and it has got less scatter. So they peak at about 2 centimeters below the skin. So I use neutrons, so you can try it. But try it for something like neutralize something. Or I would, for instance, in a scar, I will use neutrons to break up the scar, and then I'll do the fragmentation and the defrag for some of you that has got the advanced work. Now, again, here is the cell cycle. And if we look at this cycle, we've got first the growth phase. Then we've got the DNA replication. Then we've got the growth and preparation for mitosis. And then we've got the mitotic phase. And there's prophase, metaphase, anaphase, and telophase. Now, the treatment with regard radiation, it's called, the dose is called gray, Gray, but GY is the abbreviation we will see on what the doctor has prescribed. Now, what's important here is the fractionation. So it is opportunity to affect the cell during different cell phases. So it works like this. Fractionation means that I'm getting it over 6 weeks. The client will get it over 6 weeks, 5 days a week. Because we've discussed the times, how long it will take for the cell to go through all those phases. So if I have treatment over 6 weeks, some of it may be that some of the cells will be in this phase, the G1 phase, some others will be in the mitotic phase, some others will be in DNA replication. We don't know. So it is to give that opportunity to get maximum cell destruction. And this is what's called fractionation. It's also, the dose is too much just to give a once off, because then we will really kill the patient. Okay. So the safety of the patient is important. So for instance, this is just like an example. If the total that my client is going to receive is 3,500 gray in radiation, they divide it into 30, which is 116 gray per day. So 30, so this will be 6 weeks, because it's 5 days, 5 sessions per week. And then that 116 will be divided again by the fields, 5 fields of 23 gray, which means, let's say the tumor is in the breast. The machine will go from the front, and then the machine will turn, and it will turn at this angle side. It will go right underneath the client, under the bed, and then it will go this side. And so because it goes 360 degrees around, so they will decide at what angles are they going to present this tumor with radiation. Now again, here, if it's curative, it's once a day, 5 times a day for 6 weeks. That means the possibility for cure is very good. Palliative, small dose, pain control, metastasis control. It will be perhaps for 2 weeks. Okay, and it will be small doses. BodyTalk, what do we do with BodyTalk? Performance session. In the performance session, environmental vivaxis with regard the room where the radiation is. Environmental vivaxis with regard the people, the radiographers, those people, everybody else that's there. And then because they will be alone in the room, and it's just this huge, massive machine that's going to turn around them, and they've got to be very still. They must lie still. All those kind of things. And then, of course, you're going to have to focus on skin protection. What do we want? We want to protect the skin, the healthy cells. Again, it's because, remember, the skin has got fast turnover in cells. And so anything that has got a fast turnover is the first that will be affected by these therapies, because they haven't got time to replace themselves before the next therapy starts. So we can protect them. Bone marrow. Bone marrow is big, because when the radiation is there, it will affect the bone marrow, it will affect all the blood cells. And then, of course, the healthy tissue that's around that tumor. So that is what we are. And then, of course, I didn't put it in here, But what I should put it in there is then for the cancer cells, from a BodyTalk perspective, I'm focusing on that it will respond to the radiation therapy, which means that in some of the, whichever cycle it is, that it will be destroyed. Now, for instance, this picture is just the crossfire technique. So it's just to show you that this machine is just, it's not a nice picture in any case, but in any case. So it is just, it can move right around the place where the person is lying. Now the side effects. Side effects are skin, bone marrow, nausea, fatigue. Fatigue is a big one. Now again, from BodyTalk options, Wei Qi, you can obviously effectively, so Wei Qi around, if you know where's the field, we talk about the radiation field. Where is that field? What is underneath that field? What is next to that field? Above it, below it? And you are putting a Wei Qi around those areas. Wei Qi protection. Even if you haven't done module 4-7, you can just focus on Wei Qi protection against radiation in those normal tissues. Hydration, very, very good always to bring in hydration. The immune system, of course, because the immune system, all those cells are affected, especially if it's over the bone where there are bone marrows, red bone marrow where those cells are formed. And then body biovaxes in relationship to the therapy. And we can look at a lot more of those kind of things. And what one can do is for future, we can take one, I'm thinking of sort of like taking the most common cancers. And we're looking at one and we can look at how we can manage that. Then the late effects is months later, fibrosis. And then the other one, cancer. Now, sometimes for people who have had radiation, and then, and same with chemotherapy, then years later, they can have another cancer because of that effect that has been, so their cells starting to change and they can develop cancer. But it's like late effects, years and years and years. Not to say it has to happen, but it could. And then, but scars, all radiation creates from fibrosis. So scars is always there with that. Now, cancer chemotherapy, it's very new compared to surgery and radiotherapy, very new, but it's the only systemic cancer treatment. The others are both surgery, you just take out what is there. Radiation therapy is only local to where the cancer is. Cancer chemotherapy is general, systemic, because it's given through into the bloodstream and it then circulates. So it can get all those cells that have been spread and that's circulating there in the blood. So so this systemic treatment, so Galen, 2000 AD, describes cancer as a metabolic disease. And that he already said that treatment must be systemic. But those days, they used diet and purgation. So that is why they treated that. Now, in 1942, nitrogen mustard gas was accidentally led to the decrease in white blood cells. So it was a military use. Nitrogen mustard was used in its chemical warfare. That is what, so it's in military use. And again, they only realized it with the exposure of soldiers that had a low white blood cells and they got anemia. And so then they realized, but if that is happening within that situation, what can it do for, that means it can affect other cells. And that is how it was actually used then in chemotherapy. It became, and so the very first one is the alkylating agent. And so nitrogen mustard in medicine is called cyclophosphamide. So cyclophosphamide is one of the first cancer therapy chemotherapies that was used. Also very interesting because it is, if you really look at Marie Curie and how it was by not looking after themselves that they found, okay, there's an effect, so they can use it for cancer. Now here again, chemical warfare. So what happened there? Low white blood cells. So now, okay, that means we can use it for leukemia. And that is not then only leukemia patients, but they have used it in other cancers as well. So here are just like groups, like alkylating agents, antimetabolites, nitrosurias, anti-tumor antibiotics, mitotic inhibitors, and metals. Now, all of these groups are similar. So all the chemotherapies that's, for instance, under alkylating agent will affect one, will be the most affected in one of, or the most influence in one of the cell cycle sections. For instance, anti-tumor antibiotics will be, let's say, in the S phase. Or let's say antimetabolites is in the G2 phase. So again, they will give a selection of possible chemotherapy agents that could address or stop all of these cell cycle areas, which means the cancer cell doesn't matter in which one they are getting the chemotherapy that will have its biggest influence on that area. So the whole cell cycle of the cancer cell is covered, if I can use that word. It's covered. So the
Now, I have a
chemotherapy.
question.
Yeah, sure, Christina.
Just a question there. It's maybe a silly idea, but I mean, why can't they use it systemically in terms of injecting it directly into the tumor, for example?
They do. Some of them are. You can get it. You can. Some of the tumors they will put it actually arterially in the into the artery. Let's say, for instance, for bladder cancer or something, so that it's not going in via the venous.
Yes.
They have done that, but it's not that common. Not that common.
Okay. Thank you.
So chemotherapy, but that's a lovely question. Thank you. So chemotherapy, it depends on the type of tumor. So all the doctors, the oncologists, all of them, doesn't matter where they are in the world, they will belong to certain international groups. Now, I just cannot, for the life of me, I can't remember the American group because there's a huge European group and there's an American group. And so all the patients are, once the basic work is done, once they know what is the type of tumor, what is the stage, what is the grade, then the information is sent into their these groups, and they will then put their information on there. And the chemotherapy protocol that is most effectively proven for that specific tumor on the stage and the grade will be revealed and say, okay, this is the best one. And then the person will go and get that. And then they will, especially if it is in research centers, you know, like the big hospitals, universities, those kind of places. And even private oncologists, they will belong to those places. That means that the patient's information and the side effects, everything, how they do is sent there, because you just do it on the computer, of course. But it is, so they become part of this pool that gives the research generally throughout the world. And so then the drugs or the chemotherapy drugs that act at different stages of the cell cycle, that's the important thing. That's why I showed you the cell cycle. So and it's not all cancer cells, they're all different and they can all be in a different stage. So that is why these things are given like that. And then the significant toxicities affect different body systems. So for instance, if we look at alopecia, so that is falling out of the hair, the hair falls out. There are some that is not so bad for that, but the big thing is when you have a client, to let them know and to support them that the hair will grow again. The hair will grow again, sometimes more beautifully actually even than they had before. But it's anemia is big, anaphylaxis. So these are high risk areas and where they are given. I'm just telling you, you don't have to tell a patient that is a client it is high risk. I mean, anorexia, where there's no appetite, they often will get taste of metal. They just get this metal taste and they can't handle meat. Constipation or diarrhea, cystitis, and there's a lot more, skin things, nerves. But what can we do in BodyTalk? It's best to give a BodyTalk session before the chemotherapy. And I prefer to do it about 2 to 3 days before they have the therapy, because you've got 2 to 3 days to prepare the body with your formula. And then, of course, hydration again, weight you of the target organ. So because I know the organs which some of these drugs are toxic to, for instance, adriamycin, so for instance, it's an antibiotic. It means it acts like an antibiotic. It's like, if so you've got some people, they talk about the red devil or whatever because it's red. That one is specifically toxic to the heart. And there's also a limit of that. There's a limit of that in a lifetime. Once the person has received those limit, they can never have that one again. But because I know, for instance, that adriamycin is cardiotoxic, what will I do? I will do weighting of the heart against the toxicity of the adriamycin. But as a general, protect the organs, protect the liver, because the liver is the number one again. The liver must first activate that chemotherapy, whatever is given, and then it must detoxify it. That's why the liver is very important. It sometimes it struggles. When I say struggle, because it does so much work in any case for us, but it's like we put extra demands on the liver, because whatever we eat, whatever has been given into the body, it has to first activate it, and then it has to detox as well. And the other thing that you must do with chemotherapy is also same as radiotherapy. The cells where there's a big turnover, so cells that don't last a long time before they replace naturally, like the gut. So from the mouth through the gut, mouth, stomach, small intestine, large intestine, out, the mucosa layer, those cells, that membrane, the mucosa, only lasts about 3 or 5 days. So you can imagine if somebody is giving chemotherapy, it will affect those cells, those normal cells that, and the thing is the body can't keep up. So you can then often get stomatitis, you can get candida of the mouth, and that is why you have a lot of side effects in the gastrointestinal tract. But you can very effectively put away qi from the mouth right through, and focus on that. The other thing is with, now I can talk more about that, but if you think of somebody with chemotherapy, it does always ask, what did they tell you? What did they tell you about your mouth? So I will say, and sometimes they forget. They may have been told, but they forget, and I'll write it down for them. Rinse your mouth with lukewarm, a bit of salt water, and bicarb. After everything you eat, doesn't matter what you eat, rinse your mouth, because you do not want to get ulcers in the mouth. And it works very well. But if you, and it's a simple thing, but if you don't tell them, it's not going to happen. They're not going to know. And they may have told them in the clinic, but they only hear about 20% of what is being said. And then, of course, coping mechanisms. This is big. This is very big. How you work with that client of yours in how they cope. And you must remember with cancer diagnoses, it's not just that. It is the whole thing about what happens with them in their life and how the rest of the family sees it. And often you get relationships, divorces, all that kind of stuff. You get there. I had, when I was working with, in Pretoria, when I did oncology in 1980s, long time ago, and I was working in Pretoria University and HF Wood, and I worked with Dr. Fox, and I was in her clinic, and we had this beautiful patient there, and she was a breast cancer patient, and she was in the hospital, and she was terminally ill. And her husband was a professor at Wits University. And she said to me, Wilma, you better contact the professor and tell if he still wants to see his wife, he better come. In any case, I phoned him and I said to him, hi, Professor, blah, blah, blah. I said, I think if you would like to see your wife, you mustn't wait that long. He came through. I'll never forget it. It was a Thursday. Never forget it. It was a Thursday. He came. It wasn't very long. He came to see her, and off he went. And she died that same evening. He got married on Saturday. So what does it tell you? So you can never, I always say, you never know what happens behind a closed door. And when I was in charge of the Wynberg Hospital, which was mostly a cancer hospital in Cape Town, I had a registered nurse, because my experiences were so, I don't want to use the word acute, but I suppose it could be, in what I saw in family, what happens in families. That so I had a registered nurse, and her job was education and support for family members. And they could come, and we had programs for them, and patients could come with, but especially for the families, because they see things and experience things in a completely different way than what the cancer patient is experiencing things. And there's a lot of grief. People are going into grief sometimes long before it's actually necessary. And the people, the carers, are completely, they feel lonely, they feel cut off, because they don't get, everything is around the patient. And because the patient is correct, but because the patient goes through so many deep things, they are literally standing on the edge. And if we don't look after them, it's not a good idea. So the other thing with dermatological, so the skin, so if the person had radiotherapy first and they now get chemotherapy, they can get a side effect, what we call radiation recall. So it's that effect that they had, the redness and all of that during the treatment, it can come back through the chemotherapy. Photosensitivity or profound sunburn. So if somebody's on chemotherapy, ask them to stay out of the sun, and they can really get very photosensitive with brightness of light. And then, of course, erythema and hyperpigmentation. They can get hyperpigmentation with that as well. Skin rashes, metal taste, loss of taste and smell. Loss of taste and smell, that can happen as well. And then anorexia. Aches and pains, flu-like symptoms, stomatitis, nausea, vomiting, fatigue. Fatigue can be severe. I must say, with BodyTalk, it helps a lot. It helps with that fatigue as well, because you can focus on the mitochondria, and because the liver is the number one to metabolize everything. If we look after the liver, we can look better after our clients with the fatigue. Now, toxicities, that means a specific chemotherapy has a target organ for toxicity. Now, as I said, like cardiac is specifically, it is adriamycin. There's liver toxicity. There's some drugs that are very toxic to the lung, to the kidney, to the nerve, and to bone marrow. So those kind of things we look at when we know which one is going where. But as a general, I would say protect the organs through Wei Qi, and then focus on physiology of repair of the organs, because the physiology is affected. With the chemotherapy, physiology, anatomy can also be, of course, affected, but do a repair, a subsession, do subsession with physiology of repair of the whatever physiology is playing out there. So rehab of organs and functions and anatomy. Now, the choice of chemotherapy, there's always combination, so that they can, for maximum cell kill, so that they can, doesn't matter what, because we can't see at what stage the cells are in the cell cycle. So that's why they are always a combination. And it affects all cell cycle phases. And then, of course, also limited toxicity on healthy cells. They do look at that, so they can't choose things that are just all toxic into one organ. Now, how do they calculate the dose? Body surface is called the BSA, body surface area. And how does they do that? It's in square meters. So it is the weight and then the height of the person, and they work it out in square meters, and the dose is in milligrams per square meter. And so that's why when the patient comes back, they are weighed, they are doing all of that to see if a person has lost a lot of weight. That means the dose must be decreased, because they cannot give too much if the body, it must be according to the body surface area. Now, the minimum cycles of chemotherapy, and that is why, so if we think of radiotherapy and radiation therapy, for cure, it's 6 weeks. And sort of like that's done. And chemotherapy for cure, there's a very good possibility for cure. and or there may be metastases, but they're still going to go full out. The minimum is 6 months. That's 12 months or 18 months. And then that means it's every 3 weeks. That varies a lot, because what has happened with my client that I've got now, she had 1 week, then the next week it was two chemotherapies, then she had 1 week break, and then again, the 1 drug, the 2 drugs, so she had only 1 week break in between, and she had 12 cycles like that. And that is why chemotherapy is more of a long stretched out scenario. And so you have to, now for her, before every session with chemotherapy, I did do a session on her. So the misconceptions is the doctor burned the patient. I keep treating the patient that is in remission. And remember, keep treating the patient that is in remission. Sometimes a person goes into remission, but they have not completed their cycle of chemotherapy, but they will reduce the dose. And we must always remember that it is the patient's choice and that the patient consent. And what I do with I'll talk about that when I'm just finishing here now. So if we look at psychosocial quality of life issues, let's just finish that first. Adlia Stevenson said, understanding human needs is half the job of meeting them. So it's psychosocial quality of life issues are very varied and it's very different. And there's many of them. And it reflects the uniqueness of the individual and the significant others. And this is the significant others. I've got a huge feel for them, a huge empathy for them. And again, these psychosocial issues, we've got the family, we've got the community, we've got the patient, we've got the professionals. And the client is right there in the middle. And they need all of that. It's very much influenced by culture, differ at various stages of cancer, of course, the needs that are there. And we can have similar reactions in particular circumstances. Now, the patient, of course, is, if we look at the patient, they've got family, they've got work, and they've got community. And in each one of these sections, those are the things that I believe that, as far as I'm concerned, where my role as I see myself as an advocate for cancer patients, is that I've got to guide them, I've got to support them in understanding their role in this family and what is happening there. Because so often the emotional, I want to call it breakouts that's coming out there, is because of fear. And the family don't understand how they react, and the patient doesn't understand how they react. And then, of course, work, often people will lose their job. And that's not a great idea. And often people at work don't support them. The employers don't support them because they think if somebody has got no hair or somebody whatever and they can't handle and they're not supported. And so and community the same. And they will often withdraw from the community because they feel that they won't be accepted, not because they're not, but because they expect that they will not be accepted. The physical is huge because, and this again, it is body image alterations, especially if there is surgery. Let's say that a breast has been removed, or for that matter, somebody's lost a leg because of cancer, or somebody has had some surgery in the face or the neck because of cancer. So it is that there's an alteration there, and it is to be able to help them to accept that that is not who they really are, to be able to go deeper. And then, but the other thing is impaired movement. Impaired movement, not only impaired movement when they got chemotherapy, because they're sometimes so tired, they just cannot do it. And, or if they are in palliative care, that it's more difficult for them to move. It's for you to help them through that. And then dependence, it is, if they start to be dependent on anybody else, you will all know yourself. What does it feel like if you can't do what you want to do? So that is huge. And then the emotional state, these are three big ones. Hopelessness, powerlessness, and then fear. We all have fear, but I mean, this one is a big fear, because it will be fear of loss, fear of finance, fear of job, fear of loss of family, of community, fear of loss. So there's that whole, it's like, it's just there. It is it's much more prominent, and it's something that you can address. So I always ask, I first talk to them for about 20 minutes and just talk and see, what am I getting out here? What are my questions? And I'm just asking, how's the emotion today? What is it? What is happening here? And then social, impaired verbal communication. Often they withdraw. They feel that nobody will listen to them, nobody. And also because of, if there's any physical changes, they don't want to go into social environments. Chronic low self-esteem, because they does not feel themselves. They don't feel strong. They don't feel they can do certain things. And isolation is a very big one. And this is where, if you can identify ask them, have you got a friend? How are you? You're not going alone who's taking you to the clinic for your chemotherapy? Have you got a friend? Can somebody go with you? Is your husband going? Have you got a child? Who's going to take you? Really try and get them to accept help. Get them to accept that a person that can go with them and can take them for the chemotherapy. Sexuality is massive in cancer care, massive in chemotherapy, because there can be sexual dysfunction, activity intolerance due to fatigue. If they are so fatigued, they just have got no energy whatsoever for any intimacy. And there can be pain, sexual pain, when they are going through intimacy. It is this section where breakup of relationships is very common in cancer care. Very common, because of the extent, or the extent of the number of months that this person is going through chemotherapy, and that fatigue that they have, and that if that partner or that husband or wife is not really understanding this, that is where a big breakup, and that is where then they look for something else, and we can get a lot. And in breast cancer, a lot of divorces, a lot. Right. So I believe in BodyTalk, even if somebody only got access, and they do access on somebody that is having cancer, going through, it doesn't matter what therapy, they will help them in some way, because it's just that very general balances. And to parama, it really depends on where you are. You don't have to have parama. Sometimes for me, it's the simplicity of things at that stage is sometimes more important. Disentangle yourself from HO belief systems, strengthened by global acceptance, because globally they still accept those global belief systems, that age-old stuff. So let's disentangle ourselves from that. We look at the client, and what I always say to the client is sometimes, let's say, well, it doesn't matter what treatment it is, but I would sometimes say to them, it's because you've chosen to go for this, just let's work with it in a way that, okay, my body at this moment needs extra help. And this extra help is going to be surgery, chemotherapy, radiotherapy, whatever therapy that I've chosen. But it is that acceptance that my body needs extra help. And that's important, because that means we have got no judgment. We have got no judgment for Western medicine, any of those kind of things, and have no expectations. No, just get your ego out of the picture and just know that, like with my sister, her soul was done with this lifetime. Just keep the ego out of the picture and allow the client. All we have to do is to help the client to get their message. Why is this happening? What is this now what must I learn here? And let them experience that with your support. So do not take on responsibilities to want to heal a cancer patient by yourself. It's a soul experience. And the integrative approach is often needed. So don't ever think you mustn't refer somebody. So holistic in this sense is do not exclude any modality because of your belief that you have that medicine is not necessary, or only that is necessary, Okay. Now I can't remember now what I wanted to say to you when I said I'll come back to it. Can't remember at all. Can somebody remind me?
The immunotherapy.
Oh, no, not the immunotherapy. Yeah, immunotherapy. The immunotherapy, I'll tell you this interesting thing is immunotherapy, what the effect of immunotherapy is very dependable on the microbiome. And it's called Akkermansia. We have got Akkermansia in the gut. And I love Dr. William Lee, L.I., Dr. William Lee. I watch a lot of his podcasts. And he has got a whole podcast on that. He's got the whole thing. He's an oncologist. He's done, he looks at what foods has got the same effect on cancer cells as, for instance, chemotherapy. And so I just love his work. And he has got a course where he teaches people to cook real food and to say what we must really eat to be healthy. And he was explaining the one day, he said they had this patient and they were going to give her, the option was immunotherapy. And they said, well, hang on, they first want to just check how much Akkermansia she's got in her gut. And she had very low levels of Akkermansia. So they gave her Akkermansia. Now, Akkermansia is apparently, we've got different layers in the gut of microbiome. And so she was in, the Akkermansia is helping the immune system to do its job in a way. And so he they gave her the Akkermansia, and then they test again, and the Akkermansia levels was high. They gave her the immunotherapy. She healed completely. So with the research what they've done, the people that have not done well on immune therapy have no Akkermansia, or very low. So this is why, all these kind of things are playing such a big role for us. And it's very interesting, very, very interesting. Oh, the other thing that I wanted to say, I've got this client, and I didn't put her things this time I didn't want to put it in here, but she sent me a letter of appreciation. And what she is, for instance, been saying, so she was diagnosed in 2022 with a sarcoma on her right thigh. And I want to share this with you because because of the work courses you've already done. And she went to the doctor, and the doctor said, oh no, that's just a fat gland. That's fine. And so she left, and so this thing grew bigger. He didn't have it cut out. It grew bigger and bigger, and eventually she was diagnosed with this with this sarcoma. And by that stage, she then had actually lung metastases. So her treatment started, but she had to stop the treatment because she got bladder bleeding, hemorrhages of the bladder because of one of the chemotherapy. So it was like toxicity there. So they stopped it. Then another client of mine met her during Christmas and told her, and they spoke, and she said, perhaps you must just think of BodyTalk. Anyway, so she contacted me, and that was before she started chemotherapy again. And I started to work with her. Very interesting lady, very open to certain things. Immediately, that's what I do with all my clients, not even just cancer clients. I say, go get yourself a journal, and I want you to journal. Get out of what's here in the head onto paper so that it doesn't go down the body. And so she started journaling, and she would contact me and said, can we have a session because something came up in my journal about my childhood. And so she was, so then I did the session. This came up. Because I said to her, okay, what is the lesson here? What is the lesson? Have you got the lesson yet? Any case, it was when she was a child. She was one of 4 girls. She's the youngest of 4 girls. And obviously her father wanted a boy. And so she crawled out as a girl. And he called her little Maniki. He called her Maniki. So, which is now the Afrikaans for son, okay, or boy. He didn't call her on her name. He called her Maniki all the time. And then when she was, I don't know, 13 or something like that, he bought her a motorbike. Now, she's now about 56. So if you think of those years, it wasn't really the in thing for girls to ride motorbikes, probably. And then 2 years later, he bought a serious motorbike, a high-powered motorbike. So when I looked at this, I said, okay, so here's the thing. So first of all, she felt that she wasn't good enough as a woman, as a girl, as a woman. Her father called her, addressed her always like as if she's a boy. He gave her these boy toys. So it became very strong within her that she's not good enough as a woman. So I told her in her diary, in her journal, she must homework. I always give them homework. Must write down all the successes she has had as a woman in her life. And start a long time ago. That was amazing for her. Absolutely, because she suddenly had to look at herself. What did I do in my life that, as a woman that was successful, So she's been working incredibly well. But in this time, her husband works away from home. She got something that her husband is not faithful to her. Huge stresses, huge. Goes back for a checkup. There's activity again. Now, we talk about stress, and there's a American psychologist, and she says with all her studies that it is absolutely clear that stress is the cause of every disease. Now, if we look at this lady, she was diagnosed. She was then in remission. She went into remission. The chemotherapy was stopped, but then she went into remission for 18 months. She found out her husband wasn't faithful. And then all the stress, that's now massive. So what happened? How does the stress play a role there? The stress is the #1 killer of our immune system. So now the immune system cannot, there's no killer cells to address those new cells that have been active there. Anyway, so I said to her, how open will you be to do fasting? Because that is now very well researched as well. She's very open to that. And this is just something, don't suggest it if you don't know enough about it, okay? But it is a lot of it on podcasts and written, and there are. So what I suggested to her was that the day of chemotherapy, she shouldn't eat. Because one of the things that I listened to from this guy, he at stage 4, cancer of the colon, and he was in a lot of pain, and he wanted just to do the fasting. And he was in so much pain. So the oncologist said, why don't we just give you four chemotherapy for 4 weeks to control the pain? And he said, okay, he will. So the first day he was eating, and he was extremely nauseous. He had a lot of side effects. So then he decided the next week he's not going to eat anything. He had no side effects of chemotherapy, nothing. No nausea, no vomiting, nothing. Then the third week he decided he's going to eat again, just so you want to see what's happening here. He ate again while he was for the day he had chemotherapy. He was sick again. The fourth time he didn't eat anything, and he had no side effects. So but he then went on to the more serious fasting, and he's completely free. He's on 5 days of fasting, I think once a month, and there is no cancer that they can detect in his body. So it appears that, and what I said with her, so when I did the sessions was like, so this is what happens when we fast. When we fast, the cells go into protective mode because there's no food here. So it seems like the cell membrane closes up and it goes into protection. Where the cancer cells can't, because they lost that control. They lost that ability to protect themselves. They just want to eat in a way. They just want to have nutrients. And so it seems like, what I said to her, okay, I'm focusing on during the therapy that, because now the client is not eating, so there's no other nutrients in the blood that's going to circulate so that the cancer cells can absorb. So they can absorb all the chemotherapy. There's only chemotherapy in the blood that's coming now. So the cancer cells only has chemotherapy for food in a way. So they absorb all the chemotherapy. and the normal cells are protected because they protect themselves in fasting. She's doing very well. She's been at, and she's now in remission. She's now in remission after the chemotherapy, and she is said to me she is going to go, and she's going to go 5 days of fasting once a month, and we're going to see where we're going with that. So that's an alternative. This is an option, I think, because at the moment it is so real, if I can say it's real. It's really very, very good literature. It's very good research that has been done with fasting. And so it is just a very good option, for when patients are on chemotherapy. Something you can think about. Okay, is there any questions? It's no long thing, but I first thought I'll cut it in two, but never mind, we've done it now. Yes, Lorica.
Can I contact you for a fasting program or something like that?
Can you what?
Can I contact you for a fasting program or ideas on fasting?
Well, fasting is just not eat. A water fast. So you do a water fast. Let me tell you what she does. So what she's done, she did 2 days before the chemotherapy and the day of chemotherapy. And the day after chemotherapy, she will only do green juice. She will get back into green juice. There's a lot written about it. So I can have a look and see where I can sort of like guide you. And but that is basically not to eat. Because it's a shock to the body. It's the same as when they do where fasting is very good for instance, for weight loss, and that's now already a big thing. But in this situation for cancer, it is that big thing that it actually starves the cancer cells. Now there's a place in America, it's called North, I think that's something North. I'll have to look it up. But that's where they will do fasting for 40 days. And it's either a water fast or dry fast, but the people are admitted there and they are very carefully watched. And the people come out there with all kinds of diseases. They go in there for fasting, cancer, you name it, some serious stuff, and they come out there healed. Now, what for me with the fasting is like, we eat far too much, we actually eat too much. What they say, there's too much food available. If you look at our ancestors, where we come from, long time ago, there wasn't a lot of food. They ate when there was food available, but everything is just so available to us, we just eat too much. So it is, but with the fasting, just pure fasting, no other treatment, you can't do 30 days without somebody looking after you. When I say, because you got to have your tissue salts, the salts, those kind of things. But they do, and there in America, they do that dry fast as well, which means not even water, but very well, very well monitored. Very interesting. Right. Any other questions? Victoria?
No, I had gratitude actually for this. I didn't quite know what to expect, but it's been very informative and very helpful. Thank you.
You're welcome. For me, it's just for this one, it's just to give you an overall, just to get away from what other people are saying, Get away from what other people are saying. And of course, then the natural things, high dose of vitamin C, that's also very good for cancer people. And then but intravenously. So all of those things we can look at, you know. But for the main thing, and of course, meditation, I guide my people to breath work, to my clients, all clients, but especially the cancer, if I got a cancer client, is breath work, meditation, journaling, courses. They've got no choice. Every time they come, I check those. What have you done? And the breath work, there's a variation of breath works. Breath work, and you know, some of the breath work, they maintain that if you breathe properly, we can heal everything. And now, of course, we know about consciousness and all these kind of things, and it is. But for breath work, I just go. I love Dan Brulet's work, breath work, and I just keep it simple. I really keep it simple. And I say, let's just do a triangle. In for 3 or 4, out for 3 or 4, pause for 3 or 4. Because I don't want to put extra, I want something simplistic that I can actually tell my client that they can really use. And then, of course, I've got the app, the Plum Village app that I tell them all to download. I don't know if you know that, the Plum Village app. It's downloadable, free of charge, and it is of Thich Nhat Hanh. He was that Vietnamese monk. He started the walking meditations, all those. I absolutely love this work. Now, he started the Plum Village. You just download it. You see at the top or the bottom that looks like a little singing bowl. Click on it. You set up the time. Mine starts at 6 a.m., goes till 9 p.m. every half an hour. You just set it up. And then you get this beautiful bell sound. And then it's just like, okay, remind. I just drop everything, do 5 breaths, whichever one, it's a triangle, whatever you want to do. But it is that breath awareness. And this calms the body. And so that's one of the things that I'm doing, that I have to do. So that is like this. Common things, you know, the common simple simplistic things that it just makes things more natural. It's like, let's look, what can I do for me? What can I do for me, myself? That doesn't cost anything. Okay? And the other thing that I give my clients, all of them, doesn't have to have cancer, all of them, is a hypnosis of Sarah Dresser. You can just get it on YouTube. Unlock Your Life. Unlock Your Life, Sarah Dresser. Why I love her, because I can handle her voice. It's very nice. And she has got the emotional release. She's got so many things about self-esteem, about healing the whole body. Oh, it's beautiful. And I just go at night, I put that thing on, I just go to sleep. But I give it to the patients or the cancer clients, and any client, and I tell them, you know, this is while you sleep, your body can release, because we're working with all these things, emotions, beliefs. Do something else to help the body to just release it in a bigger way, you know. And I myself once, I think it was 3 times, probably in the last year, that I did a hypnosis. I mean, I do it every night when I go to sleep. I woke up in the middle of the night. I had to get up. My bed was sopping wet from perspiration. So I must have just released whatever I released. I can't remember which one I listened to, but it was amazing, absolutely amazing. Okay, so shall we say goodbye? And
Thank you so much, Roma.
Thank you for coming. It was lovely seeing all your beautiful faces. And you have a very good rest of your day or evening, Sun.
Yes.
And
Take
Miriam,
care, and thank you so much for your valuable time.
it's a pleasure. I'll be in touch.
Yeah, take care. See you, everyone.
Bye.
Thank you, Wilma.
Love you
Bye.
all. And say, San gives all my love to everybody there in Malaysia.
Will do.
Okay. Bye.
Bye.
Bye. Hello, Wilma.